so back to you again with another topic. Show of hands, who has a diabetic person in the family or has met a diabetic person? Almost everyone, right? So diabetes is one of the epidemics, endemics, whatever you want to call it, in our country and population. And it's one of the most important, one of the most serious and easily manageable diseases that we see every day. Sorry, it's not manageable, but I mean, we can control the symptoms of diabetes. We don't have a proper cure for it. So Dr. Fahad just a while ago talked about hypoglycemia. So we'll go over it very quickly, and we'll keep most of the time for the hyperglycemia. So first scenario is a 20-year-old male with altered level of consciousness brought to your emergency or brought to your hospital by an ambulance. What will you do for this patient? ABC, check the pulses, okay. So I just want to comment on one thing. So the other patient we talked about a while ago was unresponsive. This one has an altered level of consciousness. So be careful to the terms that are written or the terms that are said to you by the nurses or the staff or the attending. Altered level of consciousness or altered mental status does not have to mean that the patient is unconscious. He can be conscious, but his level of he can be conscious, but let's say his GCS is 7 or 8, conscious but not oriented, or something like that. So altered mental status, yes, you have to check the pulse, but let's assume that this patient is awake. Exactly. So in this patient, I would check the vital signs. So your nurse took your vital signs, and his heart rate was 114, slightly tachycardic, blood pressure was 128/70, temperature was 37, and satting 98 on room air, and his respiratory rate was 12. Next step. Okay, so the fifth vital sign is a glucocheck, and this scenario I kept it a bit later, and I'll tell you why. So as Dr. Muhammad told you guys in the morning, when you're approaching a patient, there's two things you have to focus on: vitals and how the patient looks. We agree on this? So this patient looks intoxicated. He is a limited historian due to his altered mental status. He is responding inappropriately or unrelated statements. You're asking him something and he's answering something else. You don't know what he's saying. So you decided to put this patient on a monitored bed. You got a glucocheck, and you asked for an ECG. Because keep in mind, in every step you're doing in the emergency, or at least the initial steps, you have to have the life-saving or critical scenarios in mind so you can take your decisions or build your approach to this patient on what you have in mind. So altered mental status, Dr. Fahad gave you a lot of differential diagnoses for altered mental status just a while ago. And when he's coming to your emergency, the priority, number one, is to the heart. And then you go to the other organs. So if he's altered, you don't have any history, you check the vital signs. The vital signs are somewhat stable. He's awake, but not that much oriented. After you do a glucocheck, please do an ECG. This patient might have some kind of cardiac abnormality. He might have an MI, PE, any one of the differentials we talked about earlier. So we did an ECG for this patient. It's a normal sinus tachycardia, nothing else. And then you do your ABCs. You check for the airway, and his airway was intact. You auscultate the chest and look for the breathing sounds. He had normal bilateral air entry, nothing in his chest. You look at his circulation. His vitals were stable initially. His pulses were intact. There's nothing to comment on the circulation. And you look at his GCS. Let's say he was altered, so I would give him a GCS of 11 or 12. Does anyone not know what GCS is? We all know GCS? Okay. So let's say his GCS was 11 or 12. And then you asked your nurse to insert 2 IV lines, and you asked for a stat BBG, and then you had your glucocheck, and it was 30. So, hypoglycemia. And as Dr. Fahad said, when you have an altered level of consciousness, and you have a cause, correct the cause, and then look for other things. Yes, he is hypoglycemic, but he might have some underlying pathology or something causing his hypoglycemia. We will deal with that later, but take it step by step. So he's hypoglycemic, and we just said the treatment for hypoglycemia, which is dextrose. So we gave him a stat bolus of dextrose, 12.5 to 25 grams of D50 dextrose, and then the patient started waking up. So after you gave him the dextrose, you started waking up and you started taking history from the relative that brought the patient to you. So you got to know that this patient is a diabetic type 1 on insulin, and you got to know that he's compliant on his medications. And focus on the history because we're going to go to it in the differential diagnosis of hypoglycemia. So he's a diabetic type 1 on insulin. He's compliant to his medications, and he has no history of drug use. When you examine the patient, so generally he has no signs of trauma, he is not agitated, he is confused, his cheeks are slightly flushed, he has a subtle JVP, it's not elevated, pulmonary chest, as we said a while ago, was clear, he's slightly tachycardic with a regular rhythm, abdomen is soft and lax, there's no masses, no tenderness at all, extremities, palpable pulses in all 4 extremities, nothing to worry about. Neurologically, he was increasingly unresponsive before you gave the dextrose, and he is moving all his limbs, but he is not following commands. So after you gave him the D50, as I said, he started waking up, and he reported to you and gave you history that he has been out with his friends that day. They were having fun, and he forgot. He took his insulin dose, but he forgot to eat his meal. So, what are the causes of hypoglycemia? So we have two causes of hypoglycemia. We can divide them into 2 groups. One of them are they diabetic in the first place, or are they not diabetic? So when the patient is diabetic or a non-diabetic patient, and he presents to you with hypoglycemia, first thing you have to think of is non-compliance to medication, or increasing his dose of insulin or oral hypoglycemics. So he could have had a higher dose of insulin or higher dose of medications, or he missed his meals, took his medication but did not take a meal. He was doing some stressful exercises, he had some alcohol ingestion, let's say the patient has increased in his weight, so he's unresponsive to the medication, or he had reduced clearance of the insulin caused by, let's say, any kind of renal failure, caused as an end stage of diabetes. These are the groups of diabetic people and what causes hypoglycemia in the diabetics. The other group is the non-diabetic patients. So when the patient is not diabetic at all, and he comes to you with a hypoglycemia, what would you suspect? So we have a mnemonic for this, and it's called explains H. Explain, which is exogenous drugs. There are some drugs that cause hypoglycemia, pituitary insufficiency, postprandial hypoglycemia, which is dumping syndrome after the gastric emptying in some kind of malignancies or surgeries, gastric surgeries, liver disease, Addison's disease, islet cell tumors. We have infections, sepsis, and pancreatic tumors, starvation, malnutrition, and hypothyroid. I know it's a long differential list. I just put it here for you guys to know. You might need to go back and read it. You just have to keep it in mind that there's a lot of. The key point I want to deliver here is that there are causes of hypoglycemia in non-diabetic. The patient doesn't have to be diabetic to get into hypoglycemia. Okay, so we'll shift gears now and go to the other side of Hypothyroid. Yes, it causes hypoglycemia. We'll explain that in a while. I'll keep your questions just until we finish, and then we'll have a question panel. So shifting to the other side of diabetes, which is, let's say you had a 17-year-old who presented to you with abdominal pain, nausea, and vomiting. And this is an extremely common presentation in these young age people. Abdominal pain, nausea, and vomiting is a presentation of a lot of diseases, right? Is it appendicitis? Is it gastritis? Is it cholecystitis? Is it DKA? Is it acute abdomen? And the list will not end. So it's very important in these kind of patients that you really identify the cause of this nausea and vomiting. Treating a simple gastritis or gastroenteritis is not like a DKA. So again, we'll go through the same approach. You ask for vital signs, and this patient was tachycardiac of 140, hypotensive, 80/60, temperature was 37.5, satting 98 on room air, and respiratory rate was high, and it was 30. So the patient presents, he was complaining of nausea, he was complaining of vomiting, abdominal pain, which started one day back before he presented to your emergency. He gave you history that he was feeling weak, lethargic, confused. In the last 3 days, he was not himself. He doesn't know what's going on. And in front of you, he was actually throwing up. So again, you connected him to the monitor, you asked for a glucose check, and you assessed his ABCs. His airway was intact, respiratory rate was slightly high, he was a bit tachypnic, using his accessory muscles, circulation, he was a bit hypotensive, so at this stage you asked for 2 IV lines, and you started a bolus of fluids. GCS was 14/15, and he was in severe abdominal pain. So you asked for lines, you ordered the stat BBG, and you ordered the chest X-ray. Glucose check was 350. So what does this mean? Is it DKA? Is this DKA? This is hyperglycemia. Is this DKA, Shabab? No. Okay. So the only information I can say now that the patient's blood sugar is high, he is hyperglycemic. I cannot say he's in DKA. So at this point, since he was hypotensive and his blood sugar is high, you would give him a bolus of fluids to treat his hypotension. We agree? Yes? Okay. So you decided to give him a bolus of normal saline, 20 ml per kg bolus, and let's say he was his weight was 60 kg, so you would give him 120 bolus, 20 per kg, and he's 60 kg, so a liter 200. Okay? A liter 200 bolus, and then you asked for your blood orders. So you decided to order a urine dipstick, urine analysis, a CBC, electrolytes, renal function panel. Why are we ordering these orders? Okay, to look for electrolyte imbalance, and in a patient that's coming to you with abdominal pains, disturbance in a young age of 16, 17, new onset, there's no history of ingestion of eating outside or any signs that would give you a clue that it's a gastroenteritis. You want to know what's going on. So we sent these labs, and then you started taking a bit of history from him. So he's having diffuse abdominal pain. It's not localized. It does not migrate anywhere. He's having fever, subjective fever this morning. It's not documented. You don't know how high it was. And he does not have any recent illness, no changes in his diet, no traveling, no contact to sick patients or chemical exposure. And he gave history that he has increased urination in the last 2 to 3 days and he does not have any dysuria. So, examination, he was alert, took person in place, he had dry mucous membranes, neck was supple, no meningeal signs, he was tachycardiac, but he did not have any murmurs, he had rapid shallow breaths, was clear chest on auscultation, diffuse abdominal tenderness, no localized pain. Extremities, he had no edema, pulses were all intact, and neurologically, he was intact. So you decide, your BBG came back, the first lab you ordered, and his pH was 7.2, bicarb was 13, and CO2 was 35. Okay, and from your electrolytes, you have the sodium of 135, chloride of 100. So, can someone read my VBG? Metabolic acidosis, that's all? Okay. Bicarb is low, okay. Metabolic acidosis. Okay, just leave the ketones. Concentrate on the BBG. So CO2 is 35. What is it? Okay. Is it compensated? Is it not compensated? Compensated? So how do you know if it's compensated or not? Okay. So it's not compensated. That's what you're saying. Okay, okay, I'll leave that. So sodium is 135 and your chloride is 100. You have, your urine analysis has positive 3 ketones. What's your next step? Calculate the anion gap. Okay, so what's the equation? Okay. So he said bicarb minus sodium plus chloride. Was that right? Okay. Wait. Sodium. Okay. Okay. Sodium plus bicarb minus chloride. Okay. Anyone here that knows it? Go ahead. Okay, without the potassium. Can you give me the equation without the potassium? Okay, so it's a sodium minus chloride plus the bicarb. Okay, so the sodium was 135, your bicarb was 15, your chloride was 100. To make this faster, the anion gap was 20. Okay. So now we have a blood sugar of 350. We have a high anion gap metabolic acidosis, and we have positive ketones in the urine. What's your diagnosis? DKA. So the key concept I want to deliver here is high blood sugar is not DKA. You have to have all 3, high blood sugar plus the ketones plus the high anion gap metabolic acidosis to say that this is a DKA. Another question, is it necessary that you have high blood sugar to have a DKA? Yes? No? Who said no? Okay, can you justify?
Maybe the patient took insulin before coming to hospital.
You heard what he said? So he said maybe the patient took the insulin dose before he came to the hospital, so he's normal glycemic or hypoglycemic? Is he still in DKA? So yes. The question here is, the answer here is yes, and this is one of the most important key points I wanted to stress on is the patient can be in DKA even with a normal blood sugar or a hypoglycemia. Because DKA does not mean high blood sugar, it means ketosis and acidosis. So, differential diagnosis, what causes DKA? It's mainly 2 things, either non-compliance to insulin or any stress to the body, any stress. So under stress, I put everything that causes stress to the body, infections, ischemias, pregnancy, hyperthyroid, medications, any kind of stressors to the body, even psychological stress, a fight with someone, bad news, anything that stresses the body may precede these patients to go to hyperglycemia and DKA. And this can be the first presentation of diabetes in most of the people in this age. So the management is 5 things: fluids, insulin, potassium, bicarb, and phosphate. Most important thing is the first two, the fluids and the insulin. So fluids, how much do you give? So the fluid deficit in DKA patients is usually mostly 3 to 5 liters of fluids. So you give an initial bolus, 20 per kg, and then you give the other bolus over 1 hour, and then you start the maintenance fluids. That's regarding the fluids. And if the patient is hypoglycemic, you give him D5 half normal saline instead of normal saline. We agree on this? Okay, we come to the insulin. So the insulin, you have to check the potassium first before you give the insulin. So you have to check the potassium in your BBG. If your potassium was low and it was less than 3.3, you do not give the insulin until you correct the potassium. If it is more than 3.3, you give 0.1 units per kg per hour of insulin. So 60 kg takes how many? 6. 60 kg takes 6 units per hour. Okay? So potassium. So to make the potassium, people always have a challenge with potassium. Always remember potassium and DKA with the rule of 5. So normal potassium above 5.5, we do not give potassium. Potassium from 3.3 to 5.5, you give 20 milliequivalent. So rule of 5 is you correct the number to 5. So 3.3 plus 20 is 5. 3 plus 2 is 5, right? You get it? And if it's lower than 3.3, you give them 30 milliequivalent until it rises above 3.3, and then you resume the insulin if you have stopped it initially, depending on the potassium level. And then we come to the bicarb. Who's with bicarb? So usually we do not give bicarb in DKA patients. Some people say that there's only one circumstance that you give bicarb, only if your pH is severely acidotic, below 6.9, plus there's decreased contractility, hypotension, and severe hypokalemia. So you have cardiac changes related to the hypokalemia, and then you give the bicarb. And then we have the phosphate. Same thing, usually don't give phosphate unless it's less than 1 with cardiac dysfunction, respiratory dysfunction, and rhabdomyolysis. Management of DKA, so one of the most important things is that you have to repeat the electrolytes every 2 hours, and the key of giving the insulin here is not the hyperglycemia. We give the insulin to correct the acidosis. So you only stop the insulin infusions and the management of DKA when you have closed the anion gap to normal. It's high, 20, you don't stop the treatment until it goes back to 12 and normalizes. So disposition of DKA patients, it depends on is it mild, moderate, or severe, depending on the level of the pH of this patient. But usually you admit them in the ward or in the ICU, depending on their status. The last point I want to make is the differences between alcoholic ketoacidosis, DKA, and HHS, which is hyperosmolar hyperglycemia. So the difference here is that in HHS, you don't have ketosis or acidosis, it's only hyperglycemia. And usually the blood sugar is very high. It's in 600, 700, it's very high. In DKA, we've talked about it, and you know the changes in it. In alcoholic ketoacidosis, it's acidosis, ketosis, hypo, or normal blood sugar. So it's hypoglycemia or normal glycemia. You got the change? So take-home messages from this talk is, remember, glucocheck is the 6th vital sign. Don't forget to ask for it when you're asking for the vital signs. In hypo or hyperglycemia, always look for the cause and treat it. And in DKA, you can have hyper or normal glycemia. Ketones and anion gap are the key in diagnosing DKA. It's not the blood sugar. Management goal is always to improve the acidosis, not the high blood sugar. And thank you very much.